video, we will discuss a few vascular lung disorders, which includes pulmonary edema and pulmonary embolism. So first, with pulmonary edema, we have an abnormal accumulation of fluid in the alveoli and the interstitial spaces. So this is different from pleural effusion. Remember, pleural effusion is in the pleural space. So pulmonary edema is typically worse. It is considered a medical emergency and it is life-threatening. The main cause of pulmonary edema is heart failure, which is also the main cause of pleural effusion, but the two disorders are very different. So when someone has pulmonary edema, it can range from very mild to very severe. So the signs and symptoms that someone has can really range, but some of those symptoms can be shortness of breath to very mild, again, to very severe, hypoxia. When you're listening to the lungs, you're hearing crackles where the fluid is. They might have accessory muscle use, so they're using all of their muscles to breathe, very fast respiratory rate. They cannot breathe laying down. As the pulmonary edema becomes worse, you'll see very anxious people. You may see some cyanotic symptoms, blue lips, blue fingertips, and they might have frothy blood-tinged sputum. So you can see when you have the normal lung, there's no fluid in the lungs, and when you have pulmonary edema, that fluid is filling up the alveoli and the interstitial spaces. So again, it can only be affecting the lower lobes of the lung, but it can also move up through the entire lung. You have some causes listed here, again, with the main cause being heart failure. But another very common cause is overhydration with IV fluids. So our patients come in and they're dehydrated, or they're here for, let's say they're here for DKA, and we're filling them up with fluids very quickly. If the person has any type of cardiac impairment or renal function impairment, we can then put the person into fluid overload, which can then represent with pulmonary edema. So if we know the problem, we're going to try to correct the cause. So if we've overhydrated them, we maybe need to diurese them. If they're having heart failure or renal failure, we'd be doing some treatment to correct that. In many cases, they might need to be transferred to the ICU because, again, this is a life-threatening condition depending on the severity of it. They should be on continuous telemetry, so continuous cardiac monitoring, oftentimes going to need oxygen, and that could range from a simple mask at 2 liters to someone actually being intubated. So again, the severity can range. Diuretics will be our main treatment. Oftentimes they're going to be receiving IV diuretics, whether they're receiving it several times a day IV push, or if they're on a continuous IV infusion, diuretics will be the main treatment for this problem. And because we have someone who is fluid overload and now we're giving them diuretics and we're changing the dynamics of their fluid volume status, vitals are extremely important, electrolyte balance, and we're going to be monitoring their input and output. Pulmonary embolism, so now a different vascular disorder, is going to be a blockage of one or more of the pulmonary arteries. So you have an embolus that traveled and now has found its home in the pulmonary arteries. So this is, again, a life-threatening condition. 10% of people with a pulmonary embolism will die within that first hour. And 30% of those people, so the people that survived, 30% of those people will die from a recurrent embolism. And so we can reduce those negative outcomes by getting these patients on anticoagulant therapy as soon as possible. So here are just some images so you can see where a pulmonary embolism can end up. And the severity of the symptoms is going to depend where that clot decides to find its home. If it's in a larger branch of the pulmonary system and it's completely occlusive, that's where you're going to see more of the patients dying within that first hour. But if it's in a smaller branch and you have lots of other vessels that are perfusing to the lung, then the patient has an increased risk for survival. So a lot of times our pulmonary embolism is caused by a clot, so deep vein thrombosis. So we know that after surgery, you have a high risk for developing a deep vein thrombosis, especially if the person has prolonged immobility after surgery. So the clot can travel from a thrombosis. If you have atrial fibrillation, because the atrium is fibrillating. Blood pools in the atrium, clots can form, and then they can travel into the pulmonary system. You can also develop a pulmonary embolism from an upper extremity clot, which is less common but can still happen, and you can see that more often with patients who have some type of central venous access device, cardiac pacing wires. Fat emboli, air emboli, tumor emboli are going to be less rare but can occur, can cause a pulmonary embolism as well. So when bones are fractured, the fat that breaks off can enter the venous system and travel to the lung. Air embolism from improper IV administration. So again, why it's extremely important to make sure we're getting all air out of our syringes and our tubing to make sure air doesn't, again, travel through the system and find its home in the pulmonary arteries. Tumor emboli, same thing. Parts of the tumor can break off and enter the bloodstream and end up in the pulmonary vasculature. Again, just more images to kind of show you how the clot can travel, can move, can come up through the aorta, travel through the heart, and end up in the lung if it isn't originated in the lung from the heart, for example, with atrial fibrillation. So risk factors, we kind of hit on some of these, but long list of risk factors. Immobility and surgery are going to be your big ones. Anybody who's had a risk, anybody who's had deep vein thrombosis or pulmonary embolism in the past, again, has risk for recurrent embolism. Malignancy has to do with those tumor emboli. Obesity, it has to do with a couple different things. Can be multiple comorbidities, but also can be venous stasis. So if you have someone who is morbidly obese, they're less likely to be moving around, more blood pooling, clots can form. And that has to do with a lot of the same things here. So I won't go through all of these, but kind of the same kind of problems we were talking about, having to do with stasis blood, with clots forming and then traveling. So with someone with a pulmonary embolism, when they initially arrive to the doctor's office or the emergency department, it can be a little bit difficult to diagnose because the symptoms can be very vague to very severe, again, depending on where the clot has lodged itself and the size of the clot. So sometimes it may be misconstrued as chest pain, so they may do a workup, a cardiac workup, but again, can be very mild dyspnea, might have some chest pain, might be coughing up some bloody sputum. When you listen to lung sounds, you may hear some decreased lung sounds, some crackles. And if they've had the clot for a while, you can also begin to see them representing with a fever as well. So diagnostic tests, there is what's called a D-dimer, and this is a blood test. This is a simple test. It's usually the first test that's done, but what you have to remember about the D-dimer is that it is predictive. It's going to tell you that the person is in a hypercoagulable state and that there might be a clot somewhere. So again, it's only predictive. It has a high probability of having false negatives, especially if the person has a small PE. It also can have false positives. So the D-dimer is a lot of times the first test that's done, but then to actually confirm that the patient has a clot, they have to do further testing. So CT scan, VQ scan, pulmonary angiogram, any of those three tests are going to let you know whether or not the patient does in fact have a pulmonary embolism. ABGs may be done to help you kind of understand the respiratory status of the patient, but that is not going to confirm whether or not they have a clot. Treatment, so we're going to make sure we're having this patient in a high Fowler's position. They're probably going to be having oxygen on. Coughing and deep breathing will be important, and they may need to have some IV fluids because if they're having a very hard time breathing, typically they're not drinking and eating, so they may need some hydration as well. It can range from very simple oxygen, 2 liters of oxygen, to in severe cases needing to be intubated and put on a ventilator. You're going to monitor this patient's respiratory and cardiac status along with their vitals very frequently, and they're going to be started on some type of anticoagulant, so you'll be monitoring their PTT, PTs, and INRs. So it will depend on the patients will have different treatment. It may be that they are put on Lovenox and Coumadin. It could be that they are put on heparin injections and Coumadin, or heparin intravenously and Coumadin. Either way, they're going to be put on a short and a long-acting medication. They have to be put on something with a very short half-life initially because we want to make sure that no further clots form and that there's no extension of the current clot. So we have to remember that these medications, heparin, Coumadin, these anticoagulants do not break up our clot that we have. It only helps prevent more clots and the extension of this clot. Coumadin takes several days to get the patient to a therapeutic range, and Coumadin is monitored with our PT and INR, where our heparin is monitored with our PTT. So it can take several days to get to that therapeutic range, and that's again another reason why they need to be on either the heparin or the Lovenox. Typically, they're going to go home with both medications, so they will need Lovenox education and Coumadin education. In some cases, they might get the clot-busting fibrinolytics, and so that isn't really discussed in this particular video, but that is another potential option for your patient. You're going to see the Coumadin and the heparin as a more common treatment. There are some complications for having a pulmonary embolism. Part of the pulmonary vasculature can die, and if that happens, you can see there being necrosis of the alveoli, you can see hemorrhage, abscesses can occur, and you might also see pleural effusion happening. So if this isn't treated right away and the person survives, you may begin to see some of these other complications. So by the time they come in for treatment, they may have all of these things going on. A long-term complication can be pulmonary hypertension as well, and that's because the patient is having long-term hypoxia, and that typically is happening when there is a very large embolus or they're having emboli that continue to recur in that area. So when that happens, you're seeing remodeling of the right ventricular and your right ventricle, and you're seeing right ventricular hypertrophy. There can be some surgical intervention at times as well. So if the clot is in an area where they want to have it removed very soon because they're worried about more negative outcomes, you can have a pulmonary embolectomy, and so that's where they're going in and they're actually going to be removing the clot. You can also have inferior vena cava filters inserted, and so this is, there's a picture coming up on the next slide we can look at. So these are put in, and they're put in to trap the clots. So as the clot moves through, let's say the aorta to get to the pulmonary vasculature, the clot will be trapped and won't be able to move any further. So the patient will continue to have to be on Coumadin so that clot that's trapped doesn't get any larger, but the clot that is trapped, the body will begin to lyse it on its own, and then the clot will eventually be dissolved. So patient teaching is going to include prevention. So if you have someone who has a pulmonary embolism, we want to teach them about preventing the possibility of having another one. If you have someone who is at risk for pulmonary embolism, we want to be talking to them about their risk factors and what they can do for that. They'll need medication teaching, lab monitoring. So if they're on Coumadin, and typically they're going to be on Coumadin for at least 6 months, and it may be the rest of their life if they have high risk factors, they're going to be monitoring their INR frequently. So we will have to teach them about that. There will be some dietary restrictions, and so we want to make sure that they have a consistent amount of vitamin K in their diet. So we're talking about green leafy vegetables, and they don't have to stop using vitamin K in their diet. They just need to make sure that they have it consistently. They want to make sure they know their signs and symptoms of recurrence, so if they feel those signs and symptoms again, they should seek treatment right away. And any follow-up, they want to make sure they know when to follow up. We talked a little bit about the inferior vena cava filter, so just a kind of a picture to show you. And this is another picture just showing you some of the different types that are out there. Okay, that concludes this video.